But what I want to do next is really just move on to our second presentation, who is Dan Weintraub. So Dan is a psychiatrist by training. So we have a very broad church. We have a geriatrician, and now we have a psychiatrist. But Dan isn't just any kind of psychiatrist. Basically, Dan is probably fair to say, and he would be a bit embarrassed by saying this, is sort of Parkinson's leading psychiatrist when it comes to research and understanding a whole bunch of phenomenology, and has been very heavily involved in a number of other initiatives, including the PPMI work from Michael J. Fox, and really leading some of our thinking about how we might better do research and studies. But what we've done today is we've asked him, if he can, to try and cover this enormous topic of what we call the neuropsychiatric symptoms and cognition in Parkinson's disease. I think it's something that comes up all the time, and I think a number of patients really struggle with these concepts. So I'm really very pleased that we have an expert in the room who will hopefully be able to take some questions. I will just point out to my own team that what Dan will do is talk in general terms. So if you have any questions about your own medical conditions, I can see anxiety disorder and PTSD and all of these things, but Dan will only be able to give general advice. So please welcome Dan Weintraub.
Good afternoon. Thank you, Simon.
I'm going to pick you up. I'll have a look at you. Pick you up, okay?
Thank you, Simon, Dr. Lewis, for the invitation to spend several days in Sydney. Simon is a friend and colleague and a great host, so it's really been wonderful being here so far. This is too broad a topic to cover in any detail, so I'll just maybe highlight some aspects of this topic, and I don't want to talk for too long, so I'd rather people have questions, comments, so I'll try to keep that in mind as well. So with that, I'll get going. And I'll try to do this deliberately so I don't get focused too much on the details of the slides and try to make some major points. So this is just the overview of psychiatry, cognition broadly, which I'm just terming neuropsychiatric symptoms encompassing lots of different things. And I think it is fair to say, and I've been doing this for 23 years now, since 2001, that non-motor symptoms are in many ways the driving force for many Parkinson's patients. I think there's a lot of good treatments for the motor symptoms of the illness, not that it's perfect, but the non-motor symptoms really lag behind in this regard. And I think for the people in the room that have Parkinson's disease or have loved ones with Parkinson's, I think you would probably agree with that, a large number of you. So these are the ones that are bolded in blue that I'll cover briefly. There's lots of non-motor neuropsychiatric symptoms, but again, you can only cover so much in a limited amount of time. So depression and anxiety, which to a psychiatrist, we kind of broadly term affective disorders. They're often linked. Psychosis, impulse control disorders, and then cognitive changes. And I really won't mention in any detail any of the other ones that are listed there, but we'll just say a few words. So many, somehow the title got lost off of this, but nothing I can do about this. This is meant to be titled caveats. So many Parkinson's patients have no psychiatric or cognitive complications. So I'm talking about this topic so it'll make it sound like everyone has this problem or problems, but it's not true. They're not the fault. If you have any one or more of these symptoms, they're not the fault of the person that is experiencing it. They don't represent weakness in any way in a person. I think my experience has been, I'm really amazed, again, in my 23 years of working with Parkinson's patients and their family members, that they cope extremely well given what a difficult illness it is for many people, that it's chronic, progressive, and sometimes disabling. And the family members and care partners, most of the people I see, I don't see alone as a patient. I typically see them with a spouse, an adult child, some other care partner, that I find those people in general to be remarkably supportive and understanding of what the patient is going through. And there is some evidence, and we had actually done a little bit of what we call qualitative research, where we interviewed patients and care partners, that illness or treatments may have unrecognized beneficial effects. It's not that anybody would wish that they have Parkinson's disease, but it doesn't also mean that there can't be some hidden benefits or unrecognized benefits. even from some of the treatments that we administer that may have some effects in terms of mood or motivation in a beneficial way, which Parkinson's patients tend to struggle with. Enhanced creativity. I'll talk a little bit about impulse control disorders, and that's more of a problem, but enhanced creativity in and of itself is not a problem. And then finally, a greater understanding and appreciation of life and relationships. And I'll just quote, this is really from an abstract of a paper that we had written, that there may be positive consequences such as personal growth as a result of personally having Parkinson's disease, or a spouse is related to greater marital equality for both members of the marital dyad. So I don't think that's true invariably, but I think it is true for many people. All right, so now we'll just dive briefly into some of the major disorders. Depression. So I think I've lost all of the titles in my slides here. I apologize for that. They're in there because I saw them this morning, but they're not showing up in the presentation. So the etiology of depression is complex because I think I titled the slide actually the Robin Williams effect. Robin Williams was somebody who was originally diagnosed with Parkinson's disease, ultimately with dementia with Lewy bodies, and took his life. But he was also somebody that had a long prior, or pre-morbid as we say, psychiatric history of substance abuse and other psychiatric problems. And it's always hard to know, when there's a bad outcome, in this case suicide, of course, what's the cause of this. So we know that people with Parkinson's disease have psychological issues that come with having a disease like this diagnosed, and there's many challenges every step of the way. But then we also know that the brain is affected in Parkinson's disease, and not only the parts of the brain that are responsible for the motor symptoms, tremor, stiffness, slowness, gait and balance problems you heard already from Dr. Henderson, but brain regions and chemicals that are responsible for mood regulation, thinking, perception. And those changes can happen actually prior to the onset of motor symptoms, which is really one of the fascinating aspects of Parkinson's disease, that some of these disorders occur before the motor symptoms start. So it really does support the biological contribution to, well, I thought you were going to make the headers of my slides show up, but you can't do that. You can only make the microphone closer.
Because you're in Australia, Dan, they're upside down. They're actually on the bottom slide. Apologies, that's my laptop has done terrible things to you.
Okay, no, that's okay. But in reality, the two are intricately linked. None of us have figured out a way yet how to separate out what's psychological or versus biological. And really, it doesn't even make sense because every thought that you have or feeling has a biological component, and many of the biological processes that are happening in our brain manifest themselves through behaviors or thoughts, feelings. This is a variant of my title. Oh, I see what's happened. They're probably just buried somehow. Okay, so what are some depression risk factors? So there's a higher frequency in females and those with cognitive impairment. But this is really true for the general population, so it's not that this is unique to Parkinson's disease. There's some question about the impact of deep brain stimulation. About 10 to 15% of Parkinson's patients get DBS or deep brain stimulation over the course of their illness and disease duration. And it's not really clear what the impact of depression is on that, or whether it matters what location you have, the subthalamic nucleus, STN, versus globus pallidus interna, GPI. But there's a lot of thoughts about that and some research. But really, the depression risk factors for depression in Parkinson's disease are very similar to the depression risk factors in the general population. So as I already said, female sex, older age, a prior family history of depression, other medical conditions. So there's really relatively little that we know that's unique to the Parkinson's process itself that contributes to depression within the illness. And it is complex, and what I'm listing here, DSM-5 is the Diagnostic and Statistical Manual, 5th edition, which is kind of the Bible for psychiatrists in terms of diagnostic criteria for various psychiatric disorders. So to meet a criteria for major depressive disorder, you need 5 of the 9 symptoms listed. And I've chosen 5 symptoms that are very common in Parkinson's disease, regardless of whether you have depression or not. So most Parkinson's patients have some disturbance in sleep. Most Parkinson's patients lose weight over time. Psychomotor changes or slowing is characteristic of the illness. Fatigue, as many people in the room would know, is very common in Parkinson's, and changes in thinking and concentration. So how do you accurately diagnose depression in Parkinson's disease? Well, we don't really have a full proof method to do that. We typically attribute the symptoms to depression if they're reported, to not deny people the opportunity for treatment. So that's one recommendation. And I find that clinically, I tend to emphasize mood changes as opposed to loss of interest or pleasure, which can overlap with other psychiatric disorders, and the cognitive symptoms of depression, which include things like feeling guilty or helpless, hopeless, as opposed to what we call the vegetative symptoms, disturbances in sleep and appetite, because they're just so common in Parkinson's anyway. We do have a fair amount of treatment evidence. I'd say of all the psychiatric conditions, we have the strongest treatment evidence in Parkinson's disease for depression. So I won't go through the details of these, but I'll just let you know that there's an older antidepressant class called tricyclic antidepressants, which have been around for about 60 years now, one in particular called nortriptyline, that's shown benefit. And when I say benefit, I mean in the kind of study that Dr. Henderson was talking about before, a randomized, controlled, double-blind study. With a placebo arm, so a fake treatment arm. So tricyclic antidepressant. SSRI stands for selective or serotonin reuptake inhibitor, and SNRI is serotonin and norepinephrine, so two brain chemicals that are affected. And these medications, paroxetine, venlafaxine, are commonly available antidepressants. So all of these have been shown to have benefit for depression and Parkinson's disease. Interestingly, one treatment that's used for Parkinson's itself, it's a dopamine agonist, and specifically pramipexole in this case, has also been shown to be efficacious for depression in one treatment study. So not just for the motor symptoms of Parkinson's, but for the mood symptoms associated with Parkinson's disease. There's been a fair amount of research now for cognitive behavioral therapy, so that's a psychotherapy or counseling technique used for depression commonly in the general population, but also in Parkinson's disease. I have a colleague at Rutgers University, Dr. Roseanne Dobkin, who's done a lot of excellent research in this regard, conducting clinical trials for in-person, telephone, and video-based cognitive behavioral therapy, showing that it works for depression and Parkinson's disease. So this is a non-pharmacological complement or replacement for treatment of depression and Parkinson's. What about the possibility of adverse effects? So whenever you're talking about the treatment of a Parkinson's disease patient with a psychiatric medication, not only do you have to think about whether it works or not, but is it going to be tolerated? So there is case literature that SSRIs, those serotonin reuptake inhibitors, can cause Parkinsonism, primarily tremor, or worsen it. But in the studies that I was mentioning before, they seem to be very well tolerated, both of the medications I was talking about from a motor standpoint. And that's been my clinical experience as well. For those of you that may have had experience with an MAOB inhibitor, so that would either be selegiline in the old days or maybe rasagiline currently, it brings up a red flag from the pharmacist immediately if you have an antidepressant co-prescribed with one of these MAOB inhibitors for this very rare but potentially serious syndrome called serotonin syndrome. I won't list all the symptoms, but we have some evidence from research that this seems to be a very rare occurrence. Probably less than 1% of patients would experience that. So I think most neurologists or psychiatrists, such as myself, fairly commonly co-prescribe these medication classes, but people need to be aware that this is a potential adverse event. So anxiety now, you would know, but I'm shifting over to anxiety here because you can't see the title of the slide, but most patients with anxiety disorder also have depression and vice versa. So they're highly what we call comorbid, co-occurring in Parkinson's disease. And my clinical experience, and I think many others as well, is that anxiety is often more disabling than depression, both psychologically distressing, but also physically distressing, because anxiety typically has a strong physical component. And the way it can present in Parkinson's disease is generalized anxiety disorder, so that's day in, day out, most of the day, anxiety, kind of excessive worrying. Sometimes people have social anxiety symptoms. That's often related to embarrassment over their Parkinson's symptoms being in a public setting. And then people sometimes can have full-blown anxiety or panic attacks. And those are often associated with fluctuations or off periods. So those for people who are treated with levodopa for long periods of time where they have good periods and then off periods a couple of hours later. Sometimes those off periods don't only have motor components, but also psychiatric components, and anxiety can be one of the most problematic ones there. for treatment of anxiety, we really have no published treatment studies. So I could say this about several psychiatric conditions, that they're really under recognized, under-treated, poorly understood. So we don't really have much evidence base to choose from in terms of treatment. So there's really been no adequate published treatment studies on anxiety other than a small trial of a medication called buspirone that many people have never even heard of. Newer antidepressants tend to have anti-anxiety effects, so they're the first-line treatment. Most antidepressants are not only approved for the treatment of major depression, but also for various anxiety syndromes in the general population. But sometimes we do need to use benzodiazepines. I often hesitate to say this in the presence of geriatricians such as Dr. Henderson, because geriatricians spend their life trying to get people off of these medication classes. But I'm seeing people that are kind of at the end of the road, so to speak. They've already gone through neurologists, sometimes other psychiatrists, and sometimes for people with really troublesome, problematic anxiety, you do have to resort to using these medications. And some of the common ones are lorazepam, alprazolam, clonazepam. But you have to really be aware of potential cognitive side effects, sedation, gait and balance problems. But I do use those, not uncommonly, actually. And there's some clinical experience at cognitive enhancing medications. So you heard about one already today, rivastigmine, may improve anxiety in those with mild cognitive deficits. So my experience has been is that people who are experiencing some of these milder deficits become anxious about them, particularly people that are younger, still working, have careers, and have a lot of responsibilities. They get anxious because they're struggling to do things in the same way that they used to do or familiar with doing. Psychosis. So psychosis, what does that mean? That means hallucinations. So those are perceptual changes, seeing, smelling, tasting, hearing, feeling something that other people aren't. Illusions or misidentifications of an actual stimulus. So there's something there, but the person misidentifies it. Passage and presence phenomena, or what we call minor psychosis symptoms, is the sense of something in the periphery of your vision, either a person or something moving. And then there's what we call delusions. So those are changes in thinking where somebody believes something to be true that other people don't believe to be true. And those are typically less common than hallucinations and more associated with severe cognitive impairment or advancing cognitive impairment. And they're often quite problematic when they occur because they tend to be what we call paranoid or persecutory in nature, so people believing that somebody's trying to harm them, hurt them in some way. So that can cause certainly trouble in the home environment. What about some of the factors associated with psychosis and Parkinson's disease? So Parkinson's medications, either in and of themselves or at higher doses or combinations of them, are all associated with this problem. Increasing severity of Parkinson's, increasing age, increasing severity of cognitive impairment. So if you look at people with significant cognitive impairment with Parkinson's, they're much more likely to have these symptoms than those that have with intact memory or thinking abilities. And there seems to be this complex interaction or contribution from various brain chemicals. So you've heard about dopamine, of course. You heard about acetylcholine today, and also serotonin, which is kind of the basis of many of the antidepressants, but also antipsychotics as well. So that's another key neurotransmitter or brain chemical for psychosis. In terms of management, so neurologists such as Dr. Lewis and some of the other people in the room typically will have a way to try to manage the Parkinson's medications. People tend to just accumulate more medications over the course of their illness. More medications are added, dosages are increased, all in the service of managing the motor symptoms. But sometimes you just hit overload and then you get psychosis as a result. So there's kind of a general recommendations about which order they should be discontinued. At the end of the day, many patients will end up just on levodopa and have everything else removed. That's one strategy anyway. In terms of antipsychotics, so AP stands for antipsychotic. It's we use those when we need to use them. So if there's, again, problems in the house or the symptoms are interfering with quality of life or function. So it's really managing the benefits, the antipsychotic benefit versus the risk, one of the primary risks being worsening Parkinsonism. There's also a literature I'm not going to refer to here in patients with dementia, so that's severe cognitive impairment, Alzheimer's disease, but it also seems to apply to Parkinson's disease as well, of a small increased risk of death and significant medical events with antipsychotic exposure. This is a little bit of a controversial literature, and it's not that it's a big increased risk, but multiple studies have shown that people should be aware of that. So what do we actually use practically in Parkinson's disease? Two antipsychotics kind of carry the day, and one is called quetiapine and the other is clozapine. Quetiapine is the neurologist antipsychotic of choice because they have the most experience and comfort with it, although we have really very little research to support its use in this population. Clozapine is an older antipsychotic that actually does show benefit in several randomized controlled trials for psychosis and Parkinson's, but is impractical to use for many patients because it requires routine blood monitoring to monitor for decreases in white blood cell count. And then in the United States, only in the United States at this point, we have a newer medication called pimavanserin that is selective just for the serotonin system. It doesn't affect the dopamine system at all. And that's kind of a novel treatment that's been available for close to a decade now in the United States. And I think at some point in other places in the world or variants of this medication will also be available. It's just not currently. A little bit about impulse control disorders. So what do I mean by that? So think of all the reasons that people go to Las Vegas, for any of you that have ever been to Las Vegas before. They've built a whole city around these 4 behaviors. So people go there to gamble, to maybe have some kind of a sexual experience, to go shopping. There's lots of high-end shopping in Las Vegas, and eating. There's great restaurants in Las Vegas. So those are the behaviors that can happen in Parkinson's disease for patients that are treated with Parkinson's medications. It doesn't happen if you're not treated. That's been studied. So if you're newly diagnosed with Parkinson's disease and haven't even initiated the Parkinson's therapy yet, you're not at increased risk for these behaviors. Most of the people that experience these behaviors never had these behaviors at any other point in their life before having Parkinson's and being on these medications. There's also some variants. There's one called dopamine dysregulation syndrome that's linked with a different medication. So I'm going to discuss dopamine agonists briefly because those are really what are linked with impulse control disorders. Dopamine agonists are pramipexole, I mentioned before, ropinirole, and rotigotine patch are the 3 primary dopamine agonists. Dopamine dysregulation is when people misuse their levodopa. They start escalating the dose, decreasing the frequency, and have this kind of emotional turmoil where they're on and can be quite irritable and labile, and then when they're off, a few hours later, they can become quite dysphoric and depressed. And hobbyism just means that people can manifest these behaviors in any number of ways, not just the 4 listed at the top. But hobbyism in general just means somebody becomes preoccupied with an activity, a task, and can't seem to let it go. It often doesn't come to completion, and they can spend many hours, they can spend overnight doing these behaviors. And for those that have been through this, I think you know what I'm referring to. So how many people actually get this problem? More than we think. Enough that dopamine agonists are no longer the first-line treatment for newly diagnosed Parkinson's patients. It used to be when I started, but not any longer. Now it's primarily levodopa or an MAO-B inhibitor. But maybe 20 to 25% of patients who are exposed to a dopamine agonist over time, they will develop one of these problems. The clinician may not be aware of it because people may not be forthcoming with this information. And it seems to be linked most closely with dopamine agonist use, although it can happen with any of the Parkinson's medications. When we did one study looking at the duration of treatment before the onset of these symptoms in those people that developed this, it was actually 4 to 5 years. So anytime I see anyone on a dopamine agonist, I ask at every visit if they're having these behaviors. You're like never out of the woods, so to speak, as long as you're on a dopamine agonist. Dopamine agonist, I mentioned, is the primary risk factor. Higher dose levodopa. What does higher dose mean? That probably once you're getting above 1,000 milligrams a day total, then you become at increased risk for having one of these behaviors. But really, they've been associated with other treatments as well, amantadine and even MAO-B inhibitors. So it's hard to tease out what the contributing factors are always because people are on multiple medications typically. There's some evidence at younger age at disease onset as a risk factor. If you're a male, you're more likely to experience some behaviors. If you're a female, you're more likely to experience others. And interestingly, if you have a family history of these behaviors, then perhaps you're at increased risk, showing there may be some genetic or other environmental influences that contribute to this. So how do you treat these symptoms? So typically the neurologist will modify, or whoever's doing the primary Parkinson's management, it could be a geriatrician, it could be a psychiatrist, will modify the Parkinson's medications and usually levodopa, similar to the psychosis story, is used to offset the decrease in dopamine agonist dose to make sure the Parkinson's symptoms aren't worsening, the motor symptoms. Sometimes people really struggle to get off these dopamine agonists once they're on it if they're having these behaviors. There's actually a syndrome called dopamine agonist withdrawal syndrome that can be quite disturbing to patients, both physically and emotionally. It's like coming off of a substance that you're quote unquote addicted to, and it's not an easy process for some people. There's some preliminary evidence, but I don't know that it's really been studied further, that either long-acting, so some of the oral medications have a long-acting form where you take it once a day versus 3-4 times a day, or a transdermal delivery, so rotigotine comes in a patch as opposed to just oral, might be associated with less of these symptoms, but I don't really know if that's true or not. Sometimes if a patient is appropriate for deep brain stimulation for motor reasons, then this is also a good reason for them to have DBS, because what does DBS allow you to do? Often to decrease the dopaminergic therapy you're receiving, and by decreasing that medication, these symptoms often improve or go away even. Psychiatric medications are used off-label. We actually did a study, a small study at our center using an opioid antagonist, because the opioid and dopamine system are linked, using a medication called naltrexone, which is FDA approved for the treatment of alcoholism. And we showed some benefit on what's called a secondary outcome measure, that it might decrease some of these behaviors. And of course, psychotherapy or counseling is very important both for the patient and for family members when one of these problems arises. And then finally, the last section I was going to mention was cognitive changes. So what can happen in terms of cognition in Parkinson's disease? So this is just kind of like a general framework that applies not only to Parkinson's disease, but more broadly to neurodegenerative diseases or aging. So people can have what we call quote unquote normal cognition, which means no appreciable change from how they've ever been. And then we have something called mild cognitive impairment, where somebody has noticed a change over time. There's some change on cognitive testing or deficit compared with people of a similar age and education and gender or sex background. But there's no significant functional impairment, so the person is still functioning day to day in a similar fashion. That's called mild cognitive impairment. Dementia is like a degree beyond that, so there's more impairment on the testing, more functional impairment, and it's really the functional impairment that gives you a diagnosis of what's called dementia, that you're not able to, manage your day-to-day activities in the same way that you used to, and you need assistance in that regard. And then we have these related diseases, as it's well beyond this conversation today, unless somebody wants to bring it up as a question or comment, and people like Simon and I will have discussions about this topic, but there's a related disorder that you may have heard of called dementia with Lewy bodies, or DLB is the acronym, but then we also have Parkinson's disease dementia, or PDD it's called, and we're still as a field trying to sort out, what are the similarities and differences between those illnesses. Sometimes people will ask me, am I going to get Alzheimer's disease? And it gets tricky because we're not talking about what might happen when you look at somebody's brain on autopsy, like the kind of work that Dr. Halliday does. But clinically, do you diagnose Alzheimer's disease in someone who has Parkinson's? And we really don't at this point. Typically, if somebody has a diagnosis of Parkinson's disease and develops cognitive changes, we don't give them a second diagnosis of Alzheimer's disease. But again, the field is evolving, and I think will change over time. What are some of the risk factors? This may sound a little bit like a broken record, but increasing age, increasing severity of Parkinson's, some question about males being more prone to this. Of course, males are more likely to have Parkinson's disease. About 60% of the population of Parkinson's seems to be males versus 40% females. But within Parkinson's, this may be an additional risk factor. Less formal education is a general risk factor. And maybe some of the particular Parkinson's features, like if you're more likely to have postural or gait instability versus a tremor predominant syndrome, that might be one association. There's a whole literature around deep brain stimulation and the cognitive changes that can occur after that, which tend to be mild and for a minority of patients. And here are some of the actual domains. So typically we talk about 5 cognitive domains, and I'm not going to go through them in detail. but executive abilities are working memories. That's your ability to plan and carry out complex activities, shift from one task to another. Attention is just your ability to sustain focus on a task. Visual spatial is your ability to navigate three-dimensional space, so the kinds of abilities you need to drive a car, for instance. Memory is your ability to learn and remember new information or past information. And then language is your ability to express yourself, to understand. And in Parkinson's, a common example is early on a complaint is word finding problems. People kind of having trouble, they know what they want to say, but they have trouble getting the words out. And any of these really can potentially be affected even early on and in mild ways. So it's not an illness where just like one domain can be affected. Like Alzheimer's disease tends to be predominantly a memory and language disorder, at least early on. Parkinson's is a little bit more varied in that regard. We have ways to screen. This is just the most commonly used instrument, or I'd say around the world, really, called the Montreal Cognitive Assessment, or MoCA. So within 10 minutes, you can get kind of a sense of how the person's doing. And I personally believe that people should be screened from this with something like this from the time of illness onset, and they should probably have it annually. I think people should have a broad neuropsychiatric screen annually, and part of that should be cognition. Otherwise, you're just going to miss things. In terms of treatment, you've heard about cholinesterase inhibitors. We have only 2 treatments that are FDA approved for Parkinson's disease neuropsychiatric symptoms. One of them is rivastigmine, this cholinesterase inhibitor for Parkinson's dementia, which seems to have significant benefits from a statistical standpoint, but probably mild benefits overall in terms of symptom improvement. And it does seem to be well tolerated for the most part, although you heard about nausea and gastrointestinal symptoms already from Dr. Henderson. There's another compound. So these were originally approved for Alzheimer's disease cholinesterase inhibitors, as was the next compound, the memantine, but they're exported for use in Parkinson's disease. And the studies of memantine have not clearly shown benefit in Parkinson's disease. So we don't really have much in the way of treatment at this point for the more advanced cognitive impairment. So what else can be done? So this is what you do on the ground clinically. So you've heard a little bit about exercise. So I think in general, we recognize that cardiovascular exercise and not being overweight is good in terms of your mental health, your cognitive health. Doing cognitive exercise is easy to recommend, although I would say the literature supporting its benefit is not clear, but there's nothing wrong or harmful about doing cognitive exercises, computer-based activities, paper and pencil type activities. Reading is a cognitive exercise. Managing vascular risk factors, that's probably key. So what is a vascular risk factor? Those are diseases that can damage blood vessels, including in the brain. Things such as high blood pressure, diabetes, high cholesterol levels. So we already know from autopsy studies that Parkinson's patients are prone to have these vascular disorders as well, and changes on the brain. So that's one thing that's somewhat under the control of people. Limiting the use of potentially harmful medications. So I talked to you about benzodiazepines. Parkinson's patients often have pain syndromes and can end up on opioids, which can be harmful for cognitive health. There's a whole class of medications called anticholinergic medications that are, again, beyond this core talk today, but can potentially harm cognition in the elderly, and people need to be aware if they're on a medication. So what's a common anticholinergic medication that an older person might take? One called diphenhydramine, or Benadryl, it's called in the United States. It's often used as a sleep aid, but yet can be harmful to some extent. Psychiatric symptoms, since they're associated with cognitive impairment, are worth treating, I think. A good night's sleep. Many Parkinson's patients also suffer from obstructive sleep apnea. Relatively few people like to use a CPAP machine, but we know that people with obstructive sleep apnea perform worse cognitively. Rapid eye movement sleep behavior disorder is also associated with cognitive changes and may improve with treatment, although we don't know that for sure. And then finally, orthostatic hypotension. So going from a sitting to a standing position where your blood pressure drops is associated with cognitive changes in the moment. So when you're lightheaded, you're not going to perform as well cognitively. So these are some of the ways of working around the margins, as we say. And then finally, just a couple of slides, and then I'm done. So this was going to be I have to guess now. This is going to be apathy, which is a decrease in initiation or engagement in activity, speech, and emotion. And it's I had to put a slide in because it's a very important disorder in Parkinson's disease, and it gets so little attention because we really don't have clear treatments for it, and it just hasn't been so well studied. But particularly care partners often complain about this, like my husband or my wife tends to sit around more, not engage, be spontaneous in terms of activity or speech anymore. And it seems to be associated with cognitive impairment and particular effects on the front part of the brain, the frontal lobes as we call them. It's not the same as depression, although they can overlap. And we do use cholinesterase inhibitors sometimes. There's been one positive study. And as a psychiatrist, I tend to use sometimes stimulating medications. So these can even be medications that are pure stimulants that are used to treat attention deficit disorder, for instance. And then fatigue is another common symptom in Parkinson's disease, which is really distinct from other psychiatric disorders, mental and physical fatigue, with very few treatment studies done to date. Sleep problems, again, that's beyond the scope of this, but I just want to say they do tend to overlap with psychiatric symptoms. REM, sleep behavior disorder, rapid eye movement sleep behavior disorder, or RBD, is the physical or verbal acting out of dreams while one's asleep. It's often called to the attention of the clinician by the care partner who's aware of it. The patient often isn't. But it leads to all kinds of issues, potentially clinically, beyond just the disrupted sleep. It's not hallucinations because they're happening during the sleeping state, not the wake state. And there are medications that are used, melatonin and clonazepam. And I'm going to skip this one because it's just, I don't want to take up more time just presenting slides. So this is a summary slide that Parkinson's disease, and I've learned this over 20 years, it's a motor disease, but it's really much more than that. It's, I think, a neuropsychiatric condition, and they're increasingly recognized as common and important. Comorbidity of these symptoms is very common, so if somebody has one of these symptoms, they're likely to have more than one. It's associated with disease-related brain changes. Nearly all of them have been. Parkinson's medications and treatments appear to have mixed effects. They can cause certain of these symptoms, but they can also maybe help treat other symptoms as well. There's still under-recognition and under-treatment of most disorders. People like Dr. Lewis and other neurologists have too much to think about when they're seeing a Parkinson's patient. There's so many different symptoms to consider that it would be impossible to prioritize all of these neuropsychiatric ones. So we still need treatments for many of these disorders as well. Some of them we have some ability to treat, but others we need to continue to develop treatments. And I think there's still a need for treatment providers with expertise in this area. People like me are far and few between. There are just not many psychiatrists that work specifically with Parkinson's patients. So I think that needs to change over time as well. And with that, I will bring it to an end. And if there's time, hopefully still for questions and comments, I'd be happy to hear what everyone else has to say.
That's wonderful. So I'll let you turn those out. Fantastic. Dan, thank you very much. It's a wonderful talk. I'm going to hopefully see if there are any questions online, getting your feedback, because I'm a bit louder than you, as you may have noticed. So the questions that always come up, so people are coming and getting, are there any special diets that people should use to help protect themselves against cognitive decline or mood changes? Can they eat themselves healthy?
No, you can probably eat yourself to poor health, but I don't know if you can eat yourself to good health. I just don't think there's much evidence. I think eating a healthy diet makes sense. I think exercising makes sense. I would never argue against any of those things. I just think we have an obligation to present what we know there's clear scientific evidence for. And I would just say the scientific evidence that doing any of those things makes a difference long term is quite limited at this point.
And I think we've got a question over here.
Since I've got both of y'all at the front of the room, it's for both of you. Relationship with CTE,
So chronic traumatic encephalopathy. Your best buddies with Chuck Adler, who's got the big program in Arizona. So I'll let you play first. And in Australia, in Australian context, we see a lot of rugby league. Obviously, NFL is probably the bigger sport that's affected in America.
Yeah. So I think there is evidence, and here I would say there is good scientific evidence. In the United States, our best evidence comes from probably football, American football, but also from our Department of Veterans Affairs. We have a large veteran population in the United States, and the studies have borne out that both post-traumatic stress disorder, or PTSD, but also traumatic brain injuries, what the term commonly used during military service, is associated with an increased risk of Parkinson's disease. So I think that's something else we can certainly recommend, is to avoid significant head trauma or brain injury. We don't really know the mechanism of how that contributes to the development of Parkinson's, but it does seem to be a risk factor.
Professor Gallagher Halliday once told me that banging your head against a subject is bad for your brain. Is that right, Professor? Yes, absolutely right. We've got a question at the back, sir.
Can you hear me?
Yes.
Great. Can you expand at all on cognitive exercises? Physical exercises have served me very well in slowing my Parkinson's down. Is there a mental gym you can use?
Lots of people recommend different things. Part of the issue with me making a personal recommendation is a lot of this is proprietary, so people develop businesses around this, and particularly like online apps or computer software programs you can engage in, but they're also trying to make money. So, I mean, I think cognitive exercise, to me, in the most basic way, just means anything that you find intellectually stimulating. And again, I think reading is a cognitive exercise. I think conversation is a cognitive exercise.
Would you class engagement with life in general as a cognitive exercise?
How do you define that when you mean engagement with life?
By not sitting at home on the sofa.
I think what you're doing right now is a good example of cognitive exercise. Coming to this meeting today, asking a question. So I think you've already crossed the threshold.
Good. The only thing I'd add to that is, I think like medicine, good medicine tastes terrible. So in actual fact, if you do cognitive exercise and you're really good at Sudoku, I'm not sure that doing Sudoku over and over and over helps so much as taking on something that's actually going to be more challenging. And so with some of those apps that are online, and we have used a bit of them with cognitive training therapies and published on them, they actually can tell you where you're weak and actually then focus those exercises towards those areas that are weak. So we're not advertising, but things like lumosity.com, brainhq.com would be reasonable sites, and we've used those resources in our research. I think there's a question, I can see was it, anyone else with a question? We've got questions online. I've got a question about wearing off periods, and we've got, the question online is more about motor wearing off, but obviously you talked about psychogenic wearing off. Essentially, we have a number of strategies to try and how we smooth that out, and probably best discuss with your specialist. But obviously, there are more frequent dosing with levodopa, the adjuvant therapies, the monoamine oxidase inhibitors that Dan talked about, the dopamine agonists, and then ultimately the smart therapies, so the pump therapies and the deep brain stimulation surgery. So we've got a question at the back. Sorry.
Yes, just a question. The current push for banning a desiccant herbicide, is your comment on that, please?
So Dan, I'll bring you back towards the microphone. This is the pesticides argument.
Yeah.
Our good friend and colleague Bas Bloom is leading the charge. The forever chemicals are getting a lot of press in Australia at the moment, by virtue of them turning up in their drinking water in some places. So the question, I guess, is related to whether we think this is going to be impact on Parkinson's disease, whether we think it's a cause of Parkinson's disease, and I guess there's a bit of data out there.
Yeah, I mean the person, one of our colleagues who's the biggest proponent of that is Dr. Ray Dorsey. Is at the University of Rochester in the United States, and he makes the claim that he thinks most of Parkinson's disease is preventable because it's of environmental contributions. But I think that's I'm just presenting that as one extreme argument. I think that's a controversial position. Yet there are individual links between multiple pesticides or other chemicals. The most recent example from the United States is at Camp Lejeune, a military base, where they saw that trichloroethylene exposure during military service was linked with an increased risk of Parkinson's disease eventually. And there are certain populations, people that live rurally or work on farms or in certain factories or industries, that seem to be at increased risk of Parkinson's. So yes, I think there is a story there to be told.
So we think it's not necessarily the whole story, but we think it's something that, again, just like banging your head against surfaces, taking pesticides, probably not good for you. There's a question in the front.
I don't know whether my question is under the umbrella of psychiatry, but I'm wondering if you had any thoughts or any dealings with Pisa syndrome, the changes of the body because of medication. Maybe it doesn't come under your area.
So Dan, as a psychiatrist, probably hasn't seen much Pisa syndrome, which essentially is camptocormia or bending of the spine. It's something that we see more so in the mimics of Parkinson's, so multiple system atrophy rather than Parkinson's disease itself. There has been some suggestion as to whether it's made worse by some of our Parkinson medication, like the dopamine agonists, and so whether withdrawing that can help those patients. But often it's a matter of it's something you want to catch early and then try and get the rehabilitation team to get the posture a bit better, I think is our mainstay of therapy.
So the posture would change, would come.
So we can improve people with PISA syndrome, but just like Parkinson's with kyphoscoliosis, which is the stoop and the shuffle, when you're down, it's really hard to get back up. So we really want to stop it early, which is why from day one we're always saying, look, you're going to hate them, but the physiotherapist is going to be your best friend. The exercise therapist is going to be your best friend. It's part of your therapy. You can't delay this. You can skip a meal, but you really can't skip out on doing any exercise. We're a bit blinded. There's a microphone at the back. Thank you.
Oh, hi. I'm sorry for coming late, but I was just wondering, I'm sort of starting into the second realm of it now because I'm 10 years in, and just wondering how much of this is relating to which phase of what you're talking about, beginning phases or end phases, or because I notice that it's divided up into about 4 phases in some graphs, and I'm just thinking, whereabouts are we talking about?
The staging question for Parkinson's. What a cookie.
Yeah, my general answer to that is there's certain things do happen. It's maybe, I don't know, stage is the word, but a duration of illness. But there's so many complicating factors in Parkinson's disease, and you've heard it before, I'm sure, but it really is true that it's there's so much heterogeneity or variability in Parkinson's disease. It gets hard to generalize across patients because you really see all different combinations. You see people with no symptoms, psychiatric, for instance, or cognitive. You see other people with multiple symptoms. Sometimes it happens early, sometimes it happens late. And so I don't know. It's really, I think in general, things like depression and anxiety, because they can be part of that, what we call this prodromal state, which is even before the motor symptoms, they tend to be common early on, but still increase in frequency over time. Things like psychosis tends to happen later with the more cognitive impairment. Things like impulse control disorders are only related to the medication use, so it just depends on when and what types of medications are introduced.
I think just to add to that some of the staging things that are out there, they were invented for one thing and then they've been used for another. So you mentioned 4 stages. I think classically people talk about the Hearn and Yahr 5 stages, but the bottom line is there may be someone who's Hearn and Yahr stage 5, can't walk independently, but cognitively they're very good. And there could be somebody who's Hearn and Yahr stage 1 where they can walk perfectly fine and they may be demented. So I think this combination of things is really hard. And I always say that Parkinson's is like a box of chocolates. Some of you are soft centres and some of you are tough nuts. So we keep working on it. There's a question over here. Oh my goodness, give that woman a microphone, damn it. So this is, you need a microphone for our Zoom feed, please, thank you. So Sister Morelia Pereira is our most experienced senior nurse, led a lot of our research, led the rural and remote approach with the Shoalhaven nurse, the Shoalhaven Australian of the Year. What year was that again? 2014. 14, there we go. Morelia, come on.
Thank you. As a health professional, one of the questions I get asked a lot by family members is how do you identify the difference between depression, apathy and pure laziness? And so family members ask for strategies in how to identify to be able to assist their loved one manage. Do you have any strategies or that can help me as a health professional pass on that information? Or
So you said laziness. Well, I typically think of laziness as kind of a trait, a character trait. And most people that are lazy have been lazy their whole life or from young adulthood or adolescence. So if they hadn't been lazy their whole life, there's no reason to think they should suddenly become lazy. So that's that one. And in depression and apathy, I think are hard to distinguish. And I tend to use the patient input at that point because the typical scenario, maybe your experience is different, is that somebody will say, I think this person's depressed, and it's a family member, and I'll say, why do you think that? And they'll say, well, they just sit around all day and don't do anything. And that's all, they got a red flag right away. I was like, well, maybe that's depression, but maybe it's not. So then I'll ask the patient, I'll say, do you feel sad or down? Do you have like the affective symptoms of depression? Or do you feel helpless, hopeless, like life isn't worth living? Or do you have feelings of guilt? And if I'm not getting any of those symptoms, then it makes it a less compelling picture for a depression diagnosis and more likely maybe to be apathy in that case.
Dan, one of the questions that comes up quite frequently in the clinic, and everyone's a bit too shy, is cannabis. I mean, you mentioned things like, the geriatricians, the geriatric salute, where they cross things off the drug chart, that benzodiazepine's got to go. But cannabis? Where are we with cannabis? Or cannabinoids?
I'd say everyone's using it, it seems, whether you have Parkinson's or not. It's, at least in the United States, it's very commonly used. I mean, lots of friends and people I know smoke marijuana commonly, and they use it for all kinds of things. And so I think that's true of Parkinson's as well. Parkinson's, you can make the case that there may be reasons that it could be beneficial. I think like pain is actually one of the more common reasons Parkinson's patients take it. Sometimes they take it for sleep. Sometimes they take it for other reasons, mood-enhancing effects. I'd say there's really almost no literature. There's lots of research going on right now about the use of cannabis and related compounds. Psilocybin is big in psychiatry, so that's a kind of a hallucinogenic type drug. But I think it's hard to recommend it clearly at this point. My main concern, having read some of the literature in the general population, is that I think people underestimate the cognitive deficits or impairments that can be induced by cannabis use, particularly chronic cannabis use, that they just assume that it's safe. And I don't know that that's true from a cognitive standpoint.
And I think it's, there's this misconception as well that there's safe cannabis, medicinal cannabis, which is safe. And of course, cannabis gets broken down into lots of other cannabinoids, and they all sort of hang around. And I mean, I guess the one study I always think about is that Israeli study, I think Nir Galadi's on it, where 10% of the patients who tried medicinal cannabis who had Parkinson's disease, and they were trying it for things like anxiety and pain, and 10% of them started hallucinating. And so, you have to be a little bit careful about these. Yeah. These things are pretty...
Yeah, that's true. I hadn't thought about the hallucinations as well. And then actually there's something I just read in a review article that I had no idea about. So cannabis is used to treat stomach upset, nausea, but there's actually a hyperemesis syndrome that it's called. That's one of the more troubling side effects that have been reported with chronic cannabis use. Hyperemesis is chronic nausea or vomiting. So even things that you didn't know were a problem, or I didn't know were a problem, may be a problem as we learn more about these medications or substances.
I think we've got one at the back.
Yeah, 15 years ago, when I started Parkinson's, we heard about people like John Pepper, who was the walking man in South Africa, who reversed symptoms of Parkinson's. And so now that's become mainstream. If we're looking in the cognitive area, where should we be looking?
So John Pepper, I don't know if you've seen this book, but basically he claimed in the book that he'd sort of cured his Parkinson's by exercise. I'm not sure how many of us see a patient that ever gets cured with Parkinson's, but the pertinent point is, what can we do early in the piece, like we do with exercise, to help our patients in this space cognitively?
Yeah, I think I listed what I could think of on the slide in terms of working, as I said, around the margins and managing other problems that can arise in people as they get older that I think are associated with cognition. I don't really know what else people can do at this point. Do you have any thoughts for yourself, or what do you think has been helpful? Or?
Yeah, there's some work done by Dr. Bredesen, who in the area of Alzheimer's, which we're looking at. Mm-hmm. It's hard to sort of translate directly, but I think there's enough there to say, look, it's worth looking at.
Okay.
I think the one thing that I would add is that stress is really bad for you. Parkinson's in particular. Now, it's really easy to say that and very hard to get rid of stress. But did you want to comment on stress? Because it's a word that the psychiatrist must hear all the time.
Yes.
I'm stressed, doctor.
Yeah. I don't know if I have much to add to that either. I feel stressed sometimes too, and I think it isn't good for you. I think it interferes with your sleep and quality of life for sure. I think it's a stressful illness. There's just no denying that. But I don't really know that we have much in the way specifically in terms of interventions that target that specifically. Yeah, I feel like I'm limited in providing answers to some of these questions, not that they're not important. Yeah, keep asking. People always have lots of experience and questions and comments.
Thank you again for your presentation.
Yeah.
I'm curious if there's been much research done on variability in cognition and mental clarity. It seems sometimes it's very sharp, and then other days it can be very dull. And for me, as a person with Parkinson's, I find that can fluctuate, and I don't understand why it fluctuates, because it doesn't. Well, stress can drive it, yes, but take that away, I still get this variability, and I don't understand if there's been any research done on that.
Yeah, I'd say there is research, some research that's been done, and then there's more being done, because I know there's people that are interested in this topic, and I think, as you've rightly identified, it's a problem and for many people, and it's not well understood. And some of it can be the time of day. So sometimes when people have cognitive impairment, there's a syndrome we call sundowning that it can occur across other illnesses like Alzheimer's disease, where typically the afternoon or early evening hours tends to be worse, and those are clearly associated with worse cognition. There's some of it could be related to the timing of the Parkinson's medication. So if you're in an off period, whenever that off period is, you may perform worse cognitively. Part of the diagnostic criteria for the related disorder I talked about, dementia with Lewy bodies, is changes in alertness or awareness. The cognitive fluctuations are inherent to the illness, and I don't think we really understand that quite so well. But when they've done things such as look at people's brain wave activities with what's called EEG or electroencephalogram, it does seem like there's alterations in brain wave activity, like a slowing that might be associated with this worsening cognition, but why it exactly happens isn't so clear. But I think you're definitely identifying a clear experience that many Parkinson's patients have. Another question up
Go
here.
on in the front, we'll get the microphone to you, and we might make this our last question.
Any comments on meditation?
Meditation, not medication, but meditation.
Yes, kind of getting asked all the things I have nothing to contribute to. Meditation, I think there's just so little known about it in Parkinson's. I'm trying to think if there have been randomized controlled trials.
It's very hard to randomise. The control arm is very difficult, isn't it?
Yeah.
That's the problem.
You can have a treatment as usual, I guess.
You can have treatment as usual, potentially, yes.
MBSR course, John Kabat-Zinn did a 8-week course here in the US.
So there are some courses, you think, but I guess what Dan is saying is that when we look at this, we want to give you the evidence base and say, okay, who's actually done a proper study? Because otherwise you're in this territory of, well, it looks like it might work. Now, I guess the good thing about it is we think it probably is going to be good for stress. It probably, as long as you're not getting ripped off and you feel as though it's helping,
right?
I wouldn't necessarily.
No, yes, without a doubt. Yeah, I was trying to think of something more concrete to say about it, but I think all the things we've been talking about, like exercise, cognitive exercise, physical exercise, mindfulness, stress reduction, are all seem to be safe and well tolerated and maybe helpful as well. So.
And we're going to take one last quick question at the back.
I like all the questions.
No, I love it. We love it.
It's more of a comment and a question.
Okay.
But I find the stress thing really hard, because you've not slept all night, and you get up and you have to do stuff, and the only thing that's ever got me through is meditation and yoga. It's the only thing, and I don't take any.
I'm so pleased you didn't say crack cocaine and cannabis. So that's wonderful.
Yeah. And have you heard of outpacing Parkinson's in Melbourne?
No.
I'm sorry,
Okay.
I didn't catch what you said.
Outpacing Parkinson's.
Outpacing Parkinson's.
And Sanjay he's a neurologist, a movement disorder specialist, and he practices meditation, and he teaches meditation and yoga. And it's worked really, really well for me.
Yep.
So I just think the whole meditation and stress factor can be a really huge.
Yeah.
And because there is research in meditation without Parkinson's people.
Well, we do have the yoga and mindfulness stuff as well. Indu, and we'll be seeing her later, I guess. But did you want to comment on this?
My only comment, and I'm sorry for being such a physician about all this stuff, but when I hear the word stress, I often think of anxiety. So I kind of medicalize the diagnosis. And I just wonder how much stress is kind of a variant of anxiety, that I just think so many Parkinson's patients have anxiety. And so I think what you're saying is one way to manage it. I think sometimes for some people medications can be helpful for stress, anxiety as well.
Wonderful. Well, look, I think we've had a wonderful presentation and discussion. Please join with me in thanking Dan. Come and sit yourself back down.